Hi, this is Kelly Mayer, and I am here to present my program Decreasing Emergency Department Visits and Readmissions Due to Dehydration in the Postoperative Bariatric Surgery Patient. Our morbidly obese population continues to increase yearly, and currently there are over 900 hospitals nationwide that are recognized as accredited bariatric surgery centers. Effects of untreated obesity account for over $480 billion in direct healthcare costs, and that was just in 2016. Bariatric surgery is a successful tool utilized for weight loss. There were over 252,000 bariatric sutures performed in 2018, and that was a 10% increase from the year before. Postoperative dehydration is a big concern for postoperative bariatric surgery patients. Many potential bariatric postoperative complications exist, but the one that is most likely preventable pertains to dehydration. And it's with education and visual tools that can assist in decreasing hospital readmissions and emergency department visits. Dehydration is related to following surgical changes that reduce the stomach pouch size. They can also have a stricture, increased nausea and vomiting after surgery, dysphagia, or painful ulcers, and not want to drink. So the number one priority for our hydration motivation safety program is education. It's education with the patients prior to surgery, while they're on the unit recovering, and after surgery going home. And safety events, reasons to reduce bariatric patients' readmissions, because, well, the unexpected cost incurred by the patient for an emergency room visit or a readmission can be exponential. Being exposed to illnesses which increase the possibility of hospital-acquired infections. The hospitals can lose out financially with Medicare patients charged with Medicare copays, and then of course sometimes hospital admissions can be associated with just unfavorable outcomes. Who are the stakeholders in this? It's the patients for the unexpected readmissions, the physicians, which their data is abstracted and submitted to bariatric registries. So when they have patients returning for dehydration, readmissions, they are dinged, and then their program can be seen as an outlier and have a higher benchmark than what's the normal. And so they could lose out on specific insurance companies participating with their programs. Of course, Medicaid also, with having to pay payments for readmissions and emergency department visits. The previous practice prior to this study improvement project was that our hospital cups weren't labeled with ounces and milliliters, so a patient wasn't able to give an accurate report to nursing staff. There weren't guidelines in practice of how full patients' cups were being routinely filled, and there wasn't any education on the importance of staying hydrated during initial pre-surgery appointments, during their stay, or really follow-up. Patients weren't educated about calling the office when they first had signs and symptoms of early dehydration as well. So this proposed project initiative on the surgical unit, of course, would need some new tools. We started with a self-tracking sheet, which was supplied on the unit where the patients are monitored after surgery. They are also given a binder with 30 days worth of these self-tracking sheets. These sheets would have small cups listed on them, and each one would represent 4 ounces. And when a patient had drank the 4 ounces at a time, they would mark through one of the cups. So it was a really easy to use QI tool. Patients were also called day before surgery to encourage pushing fluids before midnight so they arrive well hydrated before surgery. We also supplied a hospital logo cup with ounces measured on the side. We also used 5-ounce measuring disposable cups for broth and diluted juice during hospitalization, and provide the patient with a urine color chart. We also placed these in the bariatric bathrooms and sent a copy home. So it was a visual component to remind patients to sip more fluids if their urine wasn't light yellow. We also supplied cards with surgeon's office number and instructions regarding calling with first symptoms of dehydration. And then, of course, we went over the signs and symptoms of dehydration because, some people don't even realize that tachycardia, increased heart rate, is a sign of dehydration. So we would go through these and also give the card with the pictures as well for teaching tool. The benefits of making patients more accountable immediately following surgery, where they could really assist the staff with accurate PO intakes. They became more involved in really seeing how much they were drinking instead of just how much they thought they were drinking. And then this would also address any early interventions that might be needed if they weren't taking in enough, such as possibly an antiemetic to help with some nausea and vomiting to get them back on the course to drinking more. And then with the less time spent in the hospital, it was really imperative that these patients are educated preoperatively about dehydration. We would go over the dangers of severe dehydration. And our goal was to have a readmission less than 10%. We monitored this by measuring monthly inpatient and outpatient encounters, and also used a smart phrase added to the surgeon's office note to ask about outside hospital visits and hospitalizations. We had our QI project compliance looking at the self-tracker sheets and monitoring, getting those back. First, it was off to a little bit of a slow start, but that was because we just needed to do some more education on regarding where the sheets are kept and that they actually need to be saved for us and not sent with the patient's chart or sent home with the patient. We were then able to score below the benchmark average after implementing our QI hydration motivation project. So that was really, really good news. And we also made a point to do a lot of teaching with the caregivers prior to beginning this QI project. We gave a PowerPoint teaching nurses about the importance for hydration following surgery, and we continue to re-educate staff concerning new updated education. Looking at Lewin's model of change, the unfreezing was introducing the nurse manager and staff to do a quick re-education of this self-tracker sheet once a patient arrived postoperatively on their units, and immediately providing patients with measured cups, easy to access at the bedside, and filling them all at 4 ounces each time. So there was no guess as to what people were starting at. And that made for a more accurate PO intake account. The refreezing would be assessing the implementation of the sheets and measure cups and really capturing the data. And once a patient was discharged home, finding out, where was the best place to keep the sheets, what was working out for them, and working out any kinks that happened in the very beginning. We found that the educating of patients preoperatively was really a game changer because we already had them as they had to come in anyway for an education class about the surgery. And so we were able to, at that time, really go over preparing for the surgery, the different diet stages, and recognize basic needs following surgery, and how to ward off and prevent complications such as dehydration. The nursing impact, really going back and holding quarterly 10-minute catch-up meetings during already planned staff meetings was very helpful. We were able to share data involving dehydration numbers and showing them how much better we were doing since implementing this new program. And this helped really, it was more of a game changer, having the nurses have more of a buy-in after hearing that their hard work had paid off. And then it's another way to ask the nursing staff questions on how they believe the tools were working or not working, or better ways to assist these patients during their hospitalization. And once again, that just really brings them on board, as they should be, because they're the ones that are at their bedside all day long. And we really value their opinions and any ideas that they have as well. And these are my references, and I appreciate you listening to our project. Thank you.